Good afternoon. We're glad to have you join us at this FNU virtual midwifery event in celebration of National Midwifery Week. And I'm glad to be sitting here with some of my friends from Reading, Pennsylvania. So today's title is Real Life with the Team, Realities of a Multi-Setting Midwifery Practice. So we're going to hear about the successes and the challenges of the Reading Healthcare team. We're going to let them tell you all about how their practice is set up and how they work together. And then hopefully we'll be able to add Audrey Groff later, who is also in the Reading Health System. If the technology works, we'll do that. So I'm going to tell you a little bit about what I know, and then they're going to be allowed to correct it because I'm sure I'll get some of it wrong. At the Reading Healthcare System, there is a large healthcare system in which some of the practices are outlying practices. There are many private outlying practices, and that includes the birth center where Jennifer is. And then there is also an inpatient midwifery-led triage unit where Audrey is, and then Nick Camerano here is one of the physicians that backs up or that collaborates with the healthcare system, especially with the birth center. Is that right? Semi-right?
Semi-right.
Sort of right.
Yeah, sort of right.
Okay, so I'm going to read their little biographies here. Dr. Camerano is a certified OBGYN and the founder and medical director at Reading Birth and Women's Center, which is part of the Reading Health System. He serves as Chief of Obstetrics and Gynecology at Reading Hospital and Medical Center. Nick feels that there is no area of medicine more positive and rewarding than OBGYN. He enjoys being able to build lasting relationships and help patients through the most important time of their lives. He also enjoys the challenge of learning new approaches and mastering the best techniques in women's medicine. And then further to my left is Jennifer. Jennifer Stevens is a midwife, a Frontier graduate, and the director of RHPN. What does that stand for, Nick?
Reading Health Provider Network.
Reading Health Provider Network Birth Center since 2007. During this time, the practice has gone through many transitions from a private physician-owned practice to currently being under hospital ownership. The practice is very involved with the OB residency program, from demonstrating collaboration by example to inviting OB and family practice residents to chart and transfer reviews to lecturing OB staff. So they function on many levels with the residents. Jennifer has published on collaboration within her practice. She provides full-scope OBGYN care as well as in and out of hospital birth experiences, and this helps to put collaboration in action within that large teaching hospital system. Jennifer believes that practicing midwifery in this environment is always a challenge, but provides the highest level of satisfaction for the midwife and for the mother, and best of all, the high standard of care, keeping the woman at the center. So we're going to ask some questions today and give them a chance to tell us all about the way they collaborate, the challenges, the joys, and maybe even some of the pitfalls. So let's get started. So y'all correct everything I just said wrong. Now this may take all day.
Well, I don't want to be, I'm not the founder of the Reading Birth and Women's Center. Okay. I'm probably the first medical director of the Reading Birth and Women's Center, but it was really founded by a midwife who's no longer practicing, Susan Stapleton.
Susan Stapleton, shout out to my friend Susan.
I
I love Susan Stapleton. I want to be like her when I grow up. Go ahead.
Other than that, I think it was pretty accurate. The system we have is the birth center, which involves delivering at an off-site center of the hospital, out-of-hospital births. We have a group of midwives, 6 midwives, who take care of not only those clients, but also maybe 60% of our patients deliver at the hospital. All right, so
is that self-selected, like they come in and self-select?
Mm-hmm.
yeah, self-selected with, of course, there's
Guidance,
people who
right.
desire, there's guidelines, and some risk out.
Right.
So our practice is multifaceted, all right? And not to mention, all 6 midwives do a lot of GYN, and of course, that is a source of referral to me as a gynecologist when it comes to surgical treatments. So it's it's multifaceted.
I think, yeah, and the one thing just to clarify is we're actually the same practice. So although he's the collaborating physician and the medical director for the birth center, we're actually in the same office. So there's 6 midwives and 1 obstetrician in the same practice. We have 2 office sites, one being the birth center, which does office visits, prenatal care, GYN care, and then down a few steps, the births, and then the office across the really it's across town, about 10-minute drive, which is originally was Nick's office, and then when he purchased the birth center back in 2007, we kind of married those practices together over time so that we became one practice. And so the midwives go back and forth between both offices. The patients generally self-select which office they prefer to stay at in relationship to their home. Unless they're planning on delivering out of hospital, then they have to come to the birth center eventually just because of the extra educational requirements. And Nick stays only in his office. We don't let him come to the birth center. Plus, that's
Nick
where all
is
his toys
relegated
are.
to his place. I like that. Now, I understand, so I'm going to share with the audience here that you guys have home birth as well as birth center birth and hospital birth.
Correct.
So just give me an idea from an administrative standpoint. Do your midwives, do all of them flex through
Yeah.
all of that? How does that work?
Yeah, we do. Last year we did over 500 births, and closer to about 2/3 to 3/4 were in hospital. And of the out-of-hospital portion, most of those are birth center. We vary anywhere from 1 to maybe 3 home births a month. So it varies. Occasionally we'll have a 4 home birth month and then maybe none the next month. But it's a very small portion. And the home births must be within about 20 minutes of the hospital system just because of the busyness for us with the birth center and the hospital. And as our volume picked up, which it has picked up tremendously the last few years, we have actually had to make then a permanent second call position for the midwives as well, just because of having 3 places of birth and, you know, the volume that we have. Although in the home birth consent, we have it pretty clearly outlined that if there's a birth occurring at the birth center, the home birth person who becomes in active labor needs to deliver at the birth center unless there's nobody there, so that we end up keeping it only 2 sites, birth center and hospital or home and hospital, so we don't have to have a third call person.
Protocol-wise, how does that work?
Sure.
Like I have to deal with a lot of protocols with placement of students and things, so I'm always looking at,
Yeah.
you know, the appropriateness of a student placement and things like that. So sometimes I see differences in protocols for birth center and home, and what's different for you guys?
So I assume you mean the clinical practice guidelines. So for us, we treat all out-of-hospital birth the same. So we treat all birth the same, actually. So the only thing that's different is as your risk assessment changes, your place of birth changes. But other than that, the standards of care and the process of collaborating or transferring to NIC remain the same, irregardless of where you would be planning on delivering at. So we have a pretty tight process that Susan initially set up as far as how we're doing chart reviews and transfer reviews. And of course, CABC requires things like our clinical practice guidelines are kind of reviewed and approved annually. And so we're sitting down together and looking at them every year and, you know, tightening up certain things that we feel need to be addressed or reviewing things. But the same clinical practice guidelines apply to everybody.
And I mean, as an obstetrician, those clinical practice guidelines are key in order to keeping or learning to me to allow to sleep at night,
Right.
and also to keep everyone safe.
That's right.
Patients, midwives, doctor. You know,
Yeah.
It's and as soon as you stray from those guidelines, you end up in troubled waters.
It is a live
Yeah.
document, though. Like I
Yes.
feel like when we do transfer reviews and chart reviews, you know, for example, weekly Nick will review the charts of all the new OB patients. We used to sit down and do it together, but now with electronic charting, it's a little easier. And some things would right away risk somebody out. And sometimes we sit down and we have conversations about them, like, for example, having a active clot in labor would risk you out of delivering out of hospital. And we had a patient once that I think she had fractured her leg in first trimester and had a DVT. And, you know, that's a really hard sell to say she can't deliver out of hospital because the DVT was more than likely from the fracture. But our guideline said she can't deliver out. And so we had a long conversation about it. And I think in the end we ended up delivering her out of hospital because she was finished with the therapeutic anticoagulants and now is just on prophylaxis, which, you know, she was a candidate then again. So, although the guideline is there and we stick to it, when there are times where we question ourselves and say, okay, what's the evidence now? Or
Right.
a new study will come out, Nick will bring something to the table and say, hey, I want everybody to be aware of this. Or we listen to our clients too if they're challenging us. So it is a live document that we're constantly rehashing.
So I'm going to verge into waters that sometimes get a little murky for people. And we talked earlier in some sessions here about establishing effective collaboration and the challenges that can present. So I'm going to ask you all to bear your dirty laundry and tell me, this is live TV, bear your dirty laundry. Tell me some of the obstacles and the challenges and how you get past those in establishing respectful, effective, collaborating relationships.
You want to start?
Jennifer's like, I'm ready.
Well, no, I mean, I can just think of one sentence that I don't know if this is what came to mind, but the thing that Nick used to always say, because Susan used to say it, and I think we all agree, is never surprise each other. I should never be surprising him with something unexpected. He shouldn't be surprising me, and we probably shouldn't be surprising the woman either with a change in plans. And, it requires a lot of communication and a lot of work to build that level of trust with each other. But I believe he can sleep at night, not just because of the clinical practice guidelines, but he knows we're going to text or call or page or something if there's anything going on that we're like, not sure about this, or I'm getting a little nervous about this, before we need him, to
Right.
come on in quickly because we need you for something.
Well, it goes with, and Susan Stapleton is the one who taught me this. It's called mutual respect.
Absolutely.
Okay, which I think a lot of physicians who collaborate, or say they collaborate, lose sight of mutual respect. Not just I demand respect,
Right.
but I respect you, you respect me, and that should always, it's a back and forth, and that allows me, well, to be not surprised. All right, if some primary grab has been pushing for 2 hours. They call me and say, you know what, she's been pushing 2 hours, just want to let you know, but I think it's going to come out, all right? I need more time. Will you give me more time? I said, and then describe the situation, say, okay, you got the time. But now, when I get the phone call an hour later and say, you know what, it's not working, I need you now. Say, I'm already being prepared, right?
Yeah.
That's respecting my time, okay? And respecting the guidelines.
Right.
And ultimately respecting the patient's welfare. And that's what I think Jen's talking about. That's a simple example. There's more complicated ones.
Sure.
But it's always, treating people like you'd like to be treated, and I don't want to, and also in front of the patient. There's always times when we disagree on management, and I mean that's because we're intelligent people, and medicine's not an exact science, and I think it's important when there is a disagreement that it shouldn't be in plain sight of the patient. Okay,
Absolutely.
that's because when you see people who are taking care of you and fighting among themselves, you start losing confidence.
In everybody.
Right. Yes.
Yeah.
The whole system.
Right.
Yes. And you never want to put a patient, especially one in labor, in a situation like that, because they're already in a lot of
They're
angst.
so vulnerable already. Yes.
So it's
And I think that goes back to what you're talking about as far as trust. I mean, I appreciate that you say that you see other physicians who say they're doing collaboration not behaving really in that fashion. And, we talk a lot about supervision versus collaboration, and that's always a problem in midwifery, is this kind of supervisory attitude as opposed to a collaborative attitude. But I also think it goes both ways. So when, I know when I call him in, he's going to make a decision, are we going to use a vacuum forceps or section? And I also trust whatever his decision may be. I'm deeply vested in this woman having a vaginal birth. We've been working at it for hours. She's been pushing for a long time. I really hope the baby fits. But I also know that in the end, he's the one who's going to have to, deal with whatever the outcomes are of this operative delivery. And
Right.
I trust that he knows how strongly we feel, and he will make the best decision. And so we set him up for that. So when he walks in the room, we've already explained to the patient, Dr. Camerano is going to come in and he's going to evaluate things, and he may think it's best for us just to go to a C-section because we've been working really hard. But he's been doing this a really long time, and I know he will give you the best chance if that's what's recommended. That's where we should be going. So he's walking into a situation where we've kind of passed on our confidence for him to the patient, because he gives us the confidence when we call and say we need to push a little bit longer. So it allows us all to kind of support each other in that way.
Well, I don't have my collaborating physician here with me, but I do want to say that what you're saying rings true for me too. I work with a physician in rural area Georgia, and he does such a beautiful job. He's never really worked with midwives. I'm the only midwife in the area, but there's a personal mutual respect, and if I call him, let's say I call him to the office to look at something, a lesion, something odd that I've not seen, he comes in and says something immediately to put the woman at ease, and he'll say, well, I've come in, Tanya called me, but if she hasn't seen it before, I probably haven't either, but maybe between the two of us, we'll be able to figure it out. And that re-emphasizes to her, it helps her to have confidence in me and in him and in us together, that we're working together to look for the best solution. And so that mutual respect, especially in front of the client, helps them to then move forward in whatever plan is developed. So, yeah, that's great. So, okay, now, we've talked about some of the way that it works. What are some things, whether your personal experiences or others, in ways that it doesn't work? This collaboration, there's a hierarchical system in place. So how do you function within a system that really is basically hierarchical?
You mean within the hospital system or within the
Well,
practice
within,
itself?
like if you look at the United States medical healthcare system, it is a hierarchical system. So it sounds like you guys don't want to function that way, but then how do you fight that? Like, how do you fight that do you have to fight that with other physicians?
No.
No. Do you have to qualify and quantify why you're?
I guess let me put it maybe as an example of something that doesn't go on as frequently now, but it had in the past. Say there's a management question of a labor patient, and the labor and delivery nurse or a resident has an issue with it, okay? And they would pick up the phone and call me.
When we're on the
When
floor
we're on the
managing
floor.
the
Right.
patient.
And say, you know that your midwife is doing this, yada, 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 and we have an issue with it. And my first question to them is, have you discussed it with the midwife? And their answer is always no.
Right.
And I said, okay, this calls for a powwow, all right? So we're all going to get together, and we're going to talk about what the issues are and what the problems are. But the midwife's going to be in the middle of this conversation.
Well, they were calling Daddy.
Yeah.
And I think what I'm telling them, I'm not your daddy.
Right.
Okay, and so you're insisting. What you're taking away the hierarchical system.
Right.
I'm showing them I don't believe in that system. Okay, we all have something to put. We always have something to add to this situation, but we're all equal here. Okay, we just may have different things to contribute.
Right.
Yeah, they were behaving as if it was a supervisory relationship, and he was saying, no, it's not. And I think that also locally in our practice, probably the only time that really becomes an issue, because I feel through the years of working together, we both are very comfortable with our scope of practice. And I know where mine ends, and I know where his begins, and that little tiny narrow gray strip in between, we're talking. I'm calling him up, he's calling me up, we're going back and forth. But I think in our practice, the place where it's a little bit of a challenge is the third person in our collaborative, relationship, which is the woman. And that's because she sometimes is walking in feeling traumatized by the medical system. So she's got a lot of, walls put up between us, or a lot of expectations that perhaps we can't really meet. And then we are struggling trying to figure out how to work collaboratively with her. And there's been times where we've had individual women who we really had to struggle and have a lot of conversation amongst the group is, all right, how are we going to deal with this? And can she really deliver out of hospital? And can we get around an induction when we'd all feel much better if we induced her? And, one in particular comes to mind recently. And so I think we as a group struggle with collaboration more in that way. The bottom line is, as far as the hierarchical healthcare system goes, no matter how much we model and we espouse to have pure collaboration, the buck ends with Dr. Camerano. And that's going to be where it's always going to end, because that's the way the healthcare system is set up. And we're all sensitive to that. I mean, if things truly fall apart, he's the one who's going to get the call, not me. And so, I think if he's really uncomfortable with something, as much as I would love to do something slightly different or wait a little longer, I'm okay with that, because he so often has supported us and encouraged us to go with our gut. And as long as it's safe, he's willing to walk that road too. And we keep him in the loop and we explain what happened. So the very, very rare times where that happens, I think extending his ability to be the final stamp is only, respect.
Right.
Yeah.
And I think it sounds clear that he's not putting a
He's not
final
abusive
stamp
of
on
that.
it. Yeah,
He's not abusive of that.
He's
Yeah.
taking lots of things into account and in a decision-making capacity.
Yeah.
So, can you talk about the occasion that the woman in the home setting or hospital setting, home or birth center setting, does have to make the transfer? So this was not, they planned an out-of-hospital birth, and they're having to make the transfer. What are the steps, the way that you guys work it?
So antepartally, it's, usually on chart review that we're discussing a case, or the midwife upon, a diagnosis will say she's no longer eligible for out-of-hospital birth and notifies everybody. We have a secured email that we sign off to everybody at the end of every 24-hour call shift. And so any updates are always kind of added onto that. So everybody in the group, all of us, and our nursing staff and our front desk staff is all aware of changes of status like that. Intrapartally, it's always it follows CABC guidelines. So when it's identified that somebody needs to be transferred, Dr. Camerano is called, labor and delivery is called, and however the mode of transportation is, which usually is a car. If it's truly needing to be on an ambulance, then it's involving the ambulance as well. So that by the time we get to the labor floor, they're expecting us, Nick's expecting us, he can even call ahead, we call ahead. It thankfully doesn't happen often that you have true emergencies, but when you do, it's really nice to know the OR is ready, everybody's ready, he's en route, you walk in the door, and it's very smooth. Part of that's because we've been in the system for so long. We do drills every year where we call an ambulance and we go through the emergency room so they remember us. We go up to the labor floor or the NICU, depending on whether the drill's a maternal or newborn transfer. And then we do, like I said, the transfer review every 6 to 12 months, depending on how many we've had, where we all sit down and say, did we do this okay? Should we have called sooner? Or should we, have notified or communicated things differently or better? And was everybody, including the woman, really feeling like things were managed and communicated and handled in the optimal way? And including the hospital. If there's an issue where we're getting feedback, whether it's from a physician going to Nick asking about something, or the nurses, or the nurse manager, we would always include that in our review of the transfer.
So now, we were talking earlier about the OB triage unit.
Yeah.
There at Reading Health System at the receiving hospital.
Yeah.
Can you tell me a little bit about that?
Sure. Do you want me to I think it's helpful to kind of see the evolution of midwifery in the Reading system, and I mean, I'm sure you can add to it some as well, but in the early 2000s is when Audrey, and hopefully we'll have her on later, but when she was interested in going to midwifery school, my understanding is she had the hospital pay for her to go so she could come back and create this OB triage unit. So we had privileges for years already, and they saw we weren't all crazy, and obviously they were liking what they were seeing, and then decided to go into bringing midwives on hospital staff to run the OB department when the OB residents had their hours cut. And it really helped with, utilization of beds and education for the residents. Initially, it was way underutilized. I mean, they were not very integrated at all in the residents' education when you look at what's going on now. But again, you get your foot in the door, you start giving good quality care, you start creating trust between the admitting physicians would call OB triage and they'd be like, oh, oh, they did that already. Oh, okay. And you start to believe that these people actually are qualified and competent. And then, of course, 2007, Nick purchased our practice. And then 2 years ago now, the hospital purchased the practice or took over ownership of the practice. And the full kind of circle that we've done there involved the hospital trusting the midwives and also the nurses kind of taking on a belief in the different role that we're doing. A few years ago, AABC had a conference on comfort measures in childbirth, and a whole bunch of the nurses from the Reading Health System went. And part of it, I think, was in reaction to seeing us asking about intermittent monitoring or intermittent auscultation and birth balls and sterile water papules. And they're like, what is this stuff? And the ones who were interested went, many of them being some of the older nurses who were feeling like they weren't using their skills anymore, and came back and started a natural childbirth committee so that every nurse who comes through labor and delivery every year has to be trained on it.
Oh,
So,
that's wonderful.
yeah, so what's happened is you went from having an institution where midwives couldn't get privileges through an institution where some of the midwives from triage are acting as laborists and educators to the interns and working in the clinic. And we have, full scope practices, and we're there doing our midwifery stuff with the nurses, getting it and supporting it. That's a long kind of evolution. And now, the reason we were told that they were interested in acquiring the birth center is because they wanted it for marketing. Because we were one of the rare, offices that was pulling people in from different zip codes, and that was really kind of expanding the circle of the healthcare pie in the region. And we were a great marketing ploy for them. So, that's a long evolution from rolling over in your casket.
That's right.
Right.
So what else would you tell our viewers about collaborative relationships and how to make them effective and how to be able to provide this kind of wonderful care?
Well, I'd say on my side, I think as a physician, I think it's an opportunity for other OBGYNs to stay in this business longer. I mean, because, the old adage for my profession is that by the time you turn 50 years old, you better get out of OB because it's going to kill you. And then just, stay in the OR and just eke out your existence, which, I found unacceptable because I do like OB. But as you know, it's physically demanding, it's mentally demanding, and after a while, you just don't have it anymore to do it like you did it when you were in your 30s and early 40s, So this enables an obstetrician to stay in the mix, but not have the day-to-day physical and mental demand. You work with a group of trusted midwives who are good at what they do, who love what they do, and you're able to still do OB. And you do the stuff that you like. You do the forceps, you do the C-sections. You get involved in the complicated labor management without getting just hammered, and still have an decent life. And you could do this forever. I could do this forever, because it's fun and it's easy, and economically, it's the right way to go. I mean, we have an administrator who's both our boss, who sits down with us and says, "This boggles my mind." He said, "Here's a group of 6 midwives and 1 physician with a payroll that is a sixth of my other largest obstetrical group, and yet you're doing more deliveries, more surgeries, seeing more patients than anyone combined. How do you do it?"
And we have the satisfaction, the patient
and
satisfaction.
patient-
Yeah.
And the numbers that we will proudly show to anyone in the country. A C-section rate that is almost unbelievable.
Right.
What is it?
Our prime section rate's under 7 this last year.
7%.
Yeah.
That's excellent.
And they asked, "How do you do it?" And I says, open your eyes. Utilize what you have. Because there are midwives who want to be involved in this, but they keep getting no, and it's fun. You got to, so that's how I look at it, and I see midwives doing the things that they love to do. I see an obstetrician doing the things that he loves to do, and patients who feel like they're getting treated really well.
So obviously,
Yeah.
you know, as you circle back around, we end up right where we should be, which is at the woman. I mean, she's getting the best, you know, two for the price of one, for lack of a better way of saying it. She's getting all the best of all the worlds when we work well together.
I am kind of curious though. One of the things you said was that you have less work, less mental anguish, that kind of thing. And I'm thinking, I think we challenge you quite a bit mentally though, because you're obviously you have many more patients, and so we have some like crazy situations that we walk up to going like, what do you think about that? You know, really bizarre situations. It seems like we walk into all the time, and I think it keeps life interesting for you.
I love a challenge. Okay, you know, yeah, and I think there's a couple times when I say, "You guys are killing me."
Weekly, yeah.
But you know, I say that in jest because
Yeah.
it's challenging. I love it's because it's challenging. It's not mundane.
Yeah.
And believe me, these guys know OB. So when they come to me, it's because it's a tough problem.
Right.
All right. It's not
Yeah.
just something stupid. You know.
Right.
And so it puts you to task. But that's what keeps you going.
That's right. It keeps you on your toes,
That's
doesn't
right.
it?
That's what keeps you interested.
And I always feel like, I mean, for me, part of it, I feel like we are all learning from each other. Like, we'll have a woman who feels very strongly about something, and, you know, sometimes when you're really busy and you have a large practice, you're like, how important is this really? But it's really important to this woman, you
Right.
know? Or I'll go to Nick and I'll want to discuss something, and he'll be like, really? And then he'll be like, oh, well, okay, you know, and we'll have a conversation. Or he'll say to me, hey, you know, don't forget about whatever. And I'll be like, oh, yeah, you know. So I always feel like we all are learning from each other. And, you know, what he was talking about with matching the level of care to what's appropriate for the woman, to me, is what keeps it so efficient too. You know, where we would never have somebody getting, you know, continuous monitoring or an IV on every woman or all that kind of thing, no matter where they're delivering at. And, you know, that model, that kind of approach to birth that we carry through to into the hospital, I think is what keeps our statistics as good as they are and makes everybody kind of stop and go all the time. I'll have an intern come over to me and say, can I go in with you on that next birth? Do you mind? You know, because they want to know, like, what's the secret that we're doing? And the secret is we're doing nothing. We're just kind of supporting her and, you know, rubbing her back and changing her positions. And it's nothing special, but that's not what they're seeing. They're seeing, and they've got all these tasks that they've got to learn. And, you know, it helps kind of humanize the whole experience for them a little bit to come in and see us have someone on their hands and knees and rubbing their back. And you're like, oh, yeah, this is a woman becoming a mother. And, you know, it kind of just pauses them just a little in their education, I think. And it's fun to have, you know, their input and their questions and feel like you're
and what a
impacting the
difference.
next generation.
Exactly.
Of physicians.
That's
Yeah.
what is so exciting. Like, those physicians have seen something different. They have seen something that they might not see often, and but yet it's there. It's now part of the fabric of who they are and the way they're going to practice.
And they see him having fun,
Right.
you know, and they're like, huh, that's an interesting way to have a practice. Yeah.
Just today, I ran into someone from Kansas City who's opening a birth center, and had some little local pushback from the medical community. And she says, I got to tell you, I ran into an obstetrician who was willing to work with this, had some good ideas, and really kind of held everyone at bay. And he said, and you know him. He said, he was one of your residents 8 years ago.
Oh, wow.
And, you know, and I said, so how did that conversation come to be? And he said, you know, I'm willing to work with this because I've seen one of my attendings do this and it really works.
Yeah.
And she goes, well, who was that?
Right.
And then he explained it was me. You know, so I mean, you know, that's really great.
It
right?
is.
Because these young people they're listening, they're
Right.
opening their eyes, and they're spreading the word that this system works.
Like, this can work. I've
This can
seen it
work.
myself.
Yeah,
Right.
yeah. So you know, we're not wasting our time.
That's
You
right.
know, yeah.
That's good.
Thank you. And thank you for listening in today. I don't think we're going to be able to get Audrey on with us, so I hate that, but you did get to hear a good overview of the way she functions within the Reading healthcare system. So they have a wonderful collaborative system that provides for home, hospital, and birth center birth. We're excited to hear about that. We hope you'll join us for our other events this week for in this virtual event in celebration of National Midwifery Week. Thank you so much.